Thank you, sir, for this interesting webinar, and always it's a good debate. So I would be discussing some of the practical issues in children when we have to implant an IOL, whether we need to implant this in a child or whether we need to leave the child a phakic, and if we are implanting, where can we implant it, whether there is area in the bag, whether we need to put it in the sulcus or maybe behind the posterior capsule. So these are some of the points I would be discussing in my presentation. So the indications for IOL implantations in children. The first and foremost is if your axial length is more than or equal to 17 millimeters. So that's the most important part. So if you have a child with an axial length less than 16 millimeters, probably you can defer putting an IOL and leave the child a phakic until the child grows, the eyeball grows, and you have a reasonably good axial length where you can implant an IOL. The other thing to look out for is a corneal diameter. So now, even in these patients, some are microphthalmos, some have just microcornea. Probably, if you have a corneal diameter of less than 10 millimeters, you should defer putting an IOL, because what happens is that this diameter also is a diameter related to the bag. So probably you won't have a good bag also. When you have a diameter of less than 10 millimeters, there's a high chance of secondary glaucoma as well. So the age, as the consensus in the literature is that IOL should be implanted in children more than 6 months of age. Now, this is a Western literature, remember. It's not Asian literature, it's not Indian literature. Things are different here. When children don't come for follow-up, you can't be just leaving the children a phakic. And even if you put them with contact lenses, there's a risk of, there's a problem of hygiene here. Yes, spectacles are heavy. If you leave them a phakic, that's an issue. They might not wear it. They have other issues like jack-in-the-box phenomena and those kind of aberrations, which might maybe over years later have issues. Children might have issues with their vision. So, I mean, it's Western literature versus Indian literature, and one has to, you can say, strike a balance between when you would like to place an IOL. Yes, there is no consensus on younger infants, and as I told you, demographics are very important. The practical rehabilitation options, we cannot have just contact lens for everybody. We need to have other options as well, and one of the options is just why not implant an IOL. So where to implant? You have just maybe 3 or 4 areas in the eye where you can implant this. Conventional pediatric cataract surgery is like when you do your anterior capsular excision and you remove the lens matter and implant the IOL in the back. So that is what has been done in the past. There have been few case reports and also studies now which have shown that posterior optic capture is a good option in these children with the pediatric cataract. There is also, you can also have an option of anterior optic capture also in selected cases. So both types can be performed. The important thing is that you usually would not leave your IOL in the sulcus. There's so much inflammatory component in a child. There's high risk of inflammation in those young eyes. So try not to put them in the sulcus because you can have, when you have inflammation, it can just lead out to a whole range of complication. And yes, there's a bag in the lens has been proposed in Europe, and a lot of work has been done on this, but unfortunately, it's a patented lens which is available there, and we don't have that in India. So we'll have to wait for that. So routine pediatric cataract surgery, what does it involve? So routine pediatric cataract surgery, as has been shown in our first talk, is like you basically stain the capsule and perform a anterior capsular excision, which should be adequately sized. And then you remove your lens matter. And after removing the lens matter, probably what you do is do a primary posterior capsulotomy. Now, this primary posterior capsulotomy should also be of adequate size, a good size. Don't make it so small that it leads to closure, and don't make it too large that probably the IOL implantation becomes difficult. So in such cases, when I say conventional pediatric cataract surgery, the IOL is implanted in the bag after doing an ACC and a PPC. So this is a triamcinolone which you injected to see the adequacy of vitrectomy. So vitreous is clear, and you implant the IOL in the bag. So sometimes you can do a primary posterior capsulotomy before IOL implantation, or you can do it after IOL implantation. But yes, this is the, you can say, the commonest way is to implant the IOL in the bag. So it's stable there, and what literature shows is that has good results. But yes, visual opacification rates have been shown to be high as 20 to 40%. In some series, you could implant a single piece IOL, or you could implant a 3-piece IOL. Sorry. So this is so that was IOL implantation in the bag. Now the modifications which have been talked of in the literature are in the form of anecdotal case reports, or maybe a short series or so of maybe 4 or 5 patients. But yes, in all those patients, they did anterior vitrectomy, and then did a posterior optic capture. So this is what I'm going to talk about, is posterior optic capture, where you have an optic which goes behind the posterior capsule, and the haptics are in the bag. So this is done without an anterior vitrectomy. So this was a randomized study which we did, and yes, we found that the results are very gratifying, and the inflammation was much less as compared to the eye, where we did implantation in the bag. So these are bilateral cataracts. So that bias of you can say the child was removed. So you had 2 eyes of the same child. In one we did posterior optic capture, and in the other we did in the bag implantation. So just to show you one of the patients, what the posterior optic capture means is, so there, I mean, you could do it just in any patient. The advantages are that yes, you don't have to have a nice anterior capsule, or you can say a good size posterior capsule, even if the size varies. I mean, because the IOL is not going to go in the bag, the capsule size does not really matter. Yes, it should not be just too peripheral, or it should not be too small. But yes, keeping it maybe 5.5 or 4 or maybe 6 millimeters doesn't make a difference. So you just dilating the patient here using the intracameral dilator, and once it's done, the anterior rhexis was done, and then we are removing the lens matter. So the lens matter has to be removed gently in these cases. We don't, because it's quite sticky to the capsule, and we don't want just pulling out the bag or maybe causing a traction on that. So once we've done this, then what we do is a posterior rhexis. So this posterior rhexis is important. The size has to be a little larger as compared to a normal rhexis, what you would do. And yes, in such cases, you can only implant a 3-piece IOL when you want to perform a capture. So the IOL in the bag, now what we are going to do is nudge a part of it, the optic, behind the posterior capsule. So first you implant it in the bag, then the optic goes behind the posterior capsule. The haptics are in the bag, mind it. The haptics are not in the sulcus. So here you can see an oblong opening, which signifies that it's been captured very well. It's a locked IOL. It won't move anywhere. Decentration won't be there. And the other thing is, both the bag, the anterior and posterior capsule, are going to fuse because there is no optic inside the capsule. It is just the thin haptics, which doesn't leave a space for any proliferation. So this is just to show you some of the results what we have when we implanted the IOL in the bag in one eye, and in the and we performed a posterior optic capture in the other eye. So just a serial follow-up. This was published in the Indian Journal of Ophthalmology. So at 3 months, they look all good. I mean, and when you follow them for a year, you have this proliferation in the bag, which is trying. You can see some cells coming into the center as well. All these things. Whereas in the other eye, it's like a sommering ring which has formed, and there is just no proliferation outside because it's all a sealed bag. So coming to anterior optic capture, that was posterior optic capture. Now what we can do is, sometimes we can have the optic in the bag and the haptics in the sulcus. Now these are selected cases. Selected cases means especially when you have like big eyes, you have maybe anterior megaphthalmos, or you have children with buophthalmos. So I'll be just showing this small video here, where you have a child who's had buophthalmos. He had corneal opacity. He has a corneal graft done here, a beautifully done corneal graft, and has a cataract. So we need to now remove the cataract so that he has regained some kind of a vision. And the ports have to be made as you are made in any conventional pediatric cataract surgery with the 15 degrees knife. You made it. Stay in the anterior capsule. That's very important because this is a big eye. The chances are that sometimes it might just you can say go to the periphery, I mean escape to the periphery. So it's important to stain. Staining would also help you in decreasing the elasticity of the capsule. So once you stain that, you do the anterior rhexis. It's difficult in these cases. This child has had multiple surgeries, like he's had corneal transplant, he's had like a trap done as well. Twice a trap has been done. So a lot of inflammation and fibrosis is there, which has led to probably the anterior capsule is also fibrosed a bit. So one has to be careful because you don't need to have too small or too large a capsular rhexis in such cases. In ophthalmos, try to keep the rhexis slightly smaller than a conventional rhexis because you have a 5.5 millimeter optic which has to go through the anterior capsular rhexis, but it should not prolapse out. Remember that. So the rhexis has to be slightly smaller as compared to a conventional rhexis. So once we've removed that, we do a primary posterior capsulotomy. You can see here a nice round posterior capsulotomy which has been done. So that is a must because otherwise it will lead to visual axis opacification, and which we don't want. And if the child is uncooperative for a YAG or something, you will have to again take him into the operation theater. So now when you have a bag with an posterior rhexis and a bag which is larger probably, then there's a chances that the IOL might move a bit in the bag. It would not exactly fit into the bag. So do anterior vitrectomy. And then again, for the capture, you have to use a 3-piece IOL. And also in these cases where the bag is slightly larger, probably a single piece would not help you that much as compared to a 3-piece IOL. So once you put that IOL in the bags, because of the clarity of the cornea, it's not that clear here. What we did was the haptics were in the sulcus and the optic was in the bag. You can see here a diamond-shaped anterior rhexis, which is clear here. You can see here diamond-shaped and a posterior round rhexis. And a diamond shape, you can see an oval rhexis, which is same when you do a posterior optic capture. So this signifies that the IOL has been captured. And when you have a follow-up here, you can see here after a couple of months or so, this is again, you can see an oval anterior capsular rhexis and a nice round posterior capsular rhexis. So the IOL is fixed here. It won't move because it's locked by the anterior capsule, and you have a posterior opening, which will help you decrease the visual axis opacification. So you could do posterior capture or an anterior capture in selected cases. So I would like to conclude here by saying that primary IOL implantation is a good option when considering pediatric cataract surgery. Should be avoided in selected cases, as I have just enumerated. Conventional placement of IOL in the bag has issues with VAO and secondary glaucoma. Refinements in techniques such as posterior optic capture have been shown to be better in terms of inflammation. The VO is almost the same. There was no cases of opacification of the visual axis in both these series. So it's in terms of inflammation, it is better. And anterior optic capture stabilizes the IOL in eyes with ophthalmos. So that's very important in these large eye. Bag in the lens is a promising technique, but is limited by its availability. Thank you so much.
Dr. Jaspreet, it was very